Primary analysis showed a 1.9% reduction, which did cross the unity line, and therefore the conclusion may have been a bit negative. But if you read the data, the trial was significantly improved outcome, significant improvement of previous studies, and that plus concomitant systemic review and meta-analysis of all trials of continuous and prolonged infusion in the same JAMA edition, looked at 18 randomized controlled trials, 9,000 patients, and showed with good evidence that prolonged and continuous infusions did show an improvement in mortality. What it actually showed is that you needed to treat 26 patients with severe sepsis to save an extra life. So there is significant improvement. The concluding statement is a bit misleading. And because it's such an easy intervention in ICUs, in other words, a lot of drugs are given as a continuous infusion, doesn't cost much. There will be changes throughout the world over time, and it will save thousands of lives.
Can you tell us how the study's findings are going to impact and align with current conversations, discussions, and practices surrounding Sepsis Awareness Month?
Well, there should be a discussion in all intensive care units asking the question, is it only severe sepsis that needs continuous infusion, or should all patients with sepsis and some organ dysfunction have a continuous infusion introduced? So I think there will be a change. It takes time for medical practice to change. But in previous guidelines, there was a weak evidence that continuous infusions was benefit. Now there is strong evidence. So there will be changes worldwide, as I said, with an improvement in thousands of patients' lives.
And can you maybe touch on some of the best practices for antibiotic administration in sepsis management as well?
I think that by and large, we practice medicine almost in a way that is risk averse. We don't want to leave a patient with suspected infection without antibiotics. What that does is allow antibiotics to be used or produces antibiotics to be used, results in antibiotics to be used in a lot of patients that are unnecessarily non-infected, but just inflammatory response. So there will be changes over time in the diagnosis of sepsis more definitively in ICU, so that the appropriate antibiotic can be given only in those patients with sepsis. So that's the one thing. The other issue is that the long courses of antibiotics that my mother told me to use do not stop a course of antibiotics for at least a week, if not longer, is being challenged, and there'll be shorter courses of antibiotics used worldwide. So that again decreases the abuse of antibiotics and decreases the gut overgrowth of resistant organisms. So those discussions are occurring currently, and a better marker for sepsis is being investigated in a lot of places with good response, but still there's not a good marker of a lot of patients with sepsis in the ICU.